Hi everyone, this is the final completion module of our Hematology and Oncology series. With this video, we mark the end of our Hematology series, and in this video, we're going to discuss few miscellaneous topics, and we'll just try to rapidly revise and quickly summarize whatever we have learned throughout the series and the most important ones. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can do so with the link that is on the screen and that's also pinned in the description. You can contribute to us with any of these payment methods. First, let's begin by discussing about heme synthesis and porphyrias. Heme synthesis occurs in a multi-step pathway in the mitochondria and cytosol, and porphyrias are something that are related to the disorders of heme synthesis. Accumulation of toxic intermediates and that could eventually lead to neurovisceral and cutaneous symptoms. So these constitute the features of porphyrias. The first most important porphyria is acute intermittent porphyria, and it is due to a defect in the porphobilinogen deaminase, which could lead to its deficiency. The classic features includes 5Ps: painful abdomen, port wine colored urine, polyneuropathy, psychological symptoms, and it's mainly precipitated by drugs like alcohol and barbiturates. Management of acute intermittent porphyria includes treatment with glucose and hemin, as both of these inhibit ALA synthase. The most important cause for this acute intermittent porphyria is due to deficiency of porphobilinogen deaminase and due to induction of ALA synthase. So when we inhibit this ALA synthase using glucose and hemin, we we can effectively manage acute intermittent porphyria. And the other important porphyria is porphyria cutanea tarda, which is due to a defect leading to a deficiency of uroporphyrinogen decarboxylase. The clinical features of PCT includes photosensitivity, blistering skin lesions, and hyperpigmentation. It's commonly associated with hepatitis C infection, and the key concept that we have to consider whenever studying porphyria cutanea tarda is it's possibly a cutaneous porphyria, and there are no neurological symptoms, uh, just like we have discussed in acute intermittent porphyria that's comprises of neurological symptoms alongside the port wine colored urine, painful abdomen, polyneuropathy, psychological symptoms, and precipitation with drugs. But this PCT doesn't involve any neuro symptoms and is mostly concerned with cutaneous manifestations. And the other high-yield topic that we need to discuss is the tumor lysis syndrome. This tumor lysis syndrome arises because of rapid tumor cell destruction, especially after chemotherapy is initiated. So whenever chemotherapy is initiated in those patients with aggressive tumors, with aggressive and rapid cell turnover, what actually happens is there's lysis of the cells. The tumor leads to release of potassium that's inside the cells that could cause arrhythmias, and release of uric acid could lead to hyperuricemia, which could precipitate renal failure, and release of phosphate into the circulation could lead to hyperphosphatemia, and this phosphates can bind with calcium, leading to calcium phosphate crystals, which could lead to acute kidney injury. So the management of this tumor lysis syndrome involves aggressive hydration to flush out the renal stones, and the other drugs that can be used in TLS are allopurinol and raspberry. Now let's just try to quickly revise the entire hematology series, the most important and most high yield ones. So RBC disorders, first of all, to evaluate RBC disorders, we need to look at MCV, the mean corpuscular volume. Less than 80 is microcytic, 80 to 100 is normocytic, and more than 100 is macrocytic anemia. Whenever we suspect iron deficiency anemia, we need to look at ferritin levels, and that's the first most uh, important step to evaluate ferritin. And iron deficiency anemia, the characteristic feature is mostly reduced ferritin level. Thalassemia is characterized by increased red blood cells and also normal red cell distribution width. The main differentiating feature between IDA and thalassemia is that IDA has increased red cell distribution width, whereas in thalassemia there's normal RDW. G6PD deficiency is characterized by bite cells in Heinz bodies on supravital staining. Sickle cell anemia is characterized with vasoocclusion, mainly of the splenic arteries. This could lead to repeated splenic infarction, which could eventually lead to fibrosis of the spleen. While platelet disorders are concerned with mucocutaneous bleeding, TTP is because of ADAM TS13 deficiency. We have already discussed in the previous videos related to hemostasis that whenever there's ADAM TS13 deficiency, there's so ADAM TS13 is nothing but metalloprotease that is involved with the cleavage of large von Willebrand factor multimers into monomers into small fragments. So whenever there's ADAM TS13 deficiency, what happens is there is a residual large von Willebrand factor multimers, uh, which could lead to more and more aggregation and could lead to coagulation disorders. Whereas disseminated intravascular coagulation is concerned with increased prothrombin time and increased partial thromboplastin time and also reduced fibrinogen. So DIC is also called as consumptive coagulopathy because all the clotting factors are consumed, and the DIC is characterized by increased thrombosis and increased thrombolysis on the other side. Whereas HIT, heparin-induced thrombocytopenia, is associated with thrombosis and reduced platelets. Now let's just try to quickly revise the most high-yield concepts in oncology. Oncogenes, whenever there's gain of function mutation, it leads to carcinogenesis. Tumor suppressor genes, there whenever there's loss of function mutation, it leads to carcinogenesis. ALL is characterized by TDD positivity. So, and AML is concerned and characterized with characteristic OR rods in the cells, in the myeloblasts. APL is concerned with T15-17 translocation and promyelocytes. It's also associated with disseminated intravascular coagulation. CML is associated with T922 translocation, which is also called as uh, which is also involved with a characteristic Philadelphia chromosome, and the fusion protein is commonly BCR-ABL. So whenever there's fusion protein BCR-ABL, it leads to increased carcinogenesis. CLL is associated with smudge cells because of increased fragility of the cells on the peripheral smear. We'll be able to see cells that are just where the cell membrane is broken, and characteristic deformed cells are called as smudge cells. Hodgkin's lymphoma is characterized by owl-eye appearance cells uh, in the lymph nodal biopsy, and these cells are called as Reed-Sternberg cells. Whereas Burkitt's lymphoma is associated with T814 translocation, the characteristic appearance is starry sky appearance. Now let's just try to look at a vignette. So a 25-year-old patient presents with severe abdominal pain, neuropathy, and dark-colored urine. So the trigger is alcohol use. We have already discussed the 5 Ps of acute intermittent porphyria. What are those? So the 5 Ps that we have discussed about acute intermittent porphyria includes polyneuropathy, port wine colored urine, painful abdomen, psychological symptoms, and precipitation by drugs like alcohol and barbiturates. So the answer is mostly acute intermittent porphyria. A leukemia patient develops hyperkalemia, hyperuricemia, and renal dysfunction after chemotherapy is initiated. So, could possibly tumor lysis syndrome. So, hyperkalemia, hyperuricemia, hypocalcemia, hyperphosphatemia. So, all these are the metabolic symptoms of tumor lysis syndrome. Now, let's just try to quickly revise the peripheral smear and biopsy patterns, histopathological findings in different disorders in hematology and oncology. Iron deficiency anemia is associated with microcytic, hypochromic, and cells, and also anisocytosis. Anisocytosis is nothing but varied size, and poikilocytosis is nothing but varied shape. So the most characteristic feature of iron deficiency anemia on a peripheral smear is anisopoikilocytosis, along with an increased red cell distribution width. Thalassemia is characterized by characteristic target cells and also a normal red cell distribution width. Lead poisoning is associated with basophilic stippling, and sideroblastic anemia is associated with ringed sideroblasts uh, on a bone marrow image. With regards to WBC disorders, the most characteristic feature of acute myeloid leukemia is R rods. So in this image, we can see the characteristic R rods. So these are just basophilic rods, and these are associated with fragmented DNA at the peripheries. ALL is associated with large number of lymphoblasts. CLL is associated with smudge cells, and CML is associated with basophilia and increased myeloid cells. Now, coming to histology of lymph nodes in cases of lymphomas, Hodgkin's lymphoma is associated with Reed-Sternberg cells, owl eye-shaped cells. Burkitt lymphoma is associated with a starry sky appearance. Follicular lymphoma is associated with a nodular pattern. Mantle cell lymphoma, there's characteristic mantle expansion seen on a lymph nodal biopsy. And in DLBCL, diffuse large B cell lymphoma, so there are diffuse sheets of lymphoid cells. In multiple myeloma, the most characteristic feature is a Rayleigh's formation, or just like stacking, where the RBCs stack like coins. And there's also characteristic M spike on serum protein electrophoresis, along with punched out lytic lesions on lower bone lesions. And also there's the characteristic clock phase chromatin, as we can see in this image. R-rods, AML, smudge cells, CL, Reed-Sternberg cells, Hodgkin's, starry sky buckets. Rayleigh's is associated with multiple myeloma, bite cells in Heinz bodies, which is XPD deficiency, target cells in thalassemia, cystocytes in microangiopathic hemolytic anemia because of the mechanical trauma and all. Hypersegmented neutrophils are mainly seen with vitamin B12 deficiency and also folate deficiency. The characteristic feature which differentiates B12 deficiency from folate deficiency is that in folate deficiency there is no polyneuropathy or peripheral neuropathy, whereas in B12 deficiency there is characteristic peripheral neuropathy. Ringed sideroblasts are seen in sideroblastic anemia. I hope the series helped you. So the series is designed with a motto to end burnout and empower active learning, where we just help ourselves to get some time to just sit down and read our book actively rather than just passively watching endless lectures. So how this series helps you is that this helps you understand what's actually tested on the exams, how it's actually tested, how the pattern recognition can be done with regards to questions on USMLE or NEET PG or INICET. So this has to be done in a systematic way. So these videos are designed just like we watch these videos and then we just straightforward go to our book and spend a lot of time on reading a book by others rather than just listening to something or watching something. So when you just sit down and read actively, that makes a difference. And I hope this series helped you. I'll be right back with many more interesting videos and high lecture series. Before ending the video, I would like to request all of you to subscribe so that you can you can stay tuned with our series. Thank you so much. Bye.